record. Hi Aslani, how have you been? Time flies. You've been back from Mayo for how long now?
I think almost 1 year.
Yeah. So Dr. Aslani was in Mayo doing research and also a lot more. He's written a lot of papers and been publishing it. Even until now, you've been publishing papers, right? Since you're back.
Yep. I continue doing it.
And he has one of the biggest archive of echo that one can imagine, and all the most interesting cases. So without further ado, let's come. Aslani, I'm dying to see your echoes.
Sure. All right, so let me share my screen again. And let me go into a slide mode. All right, so thank you everyone. Thanks for joining me and Dr. Betty in today's webinar. So basically today, because I got a lot of echo cases since I come, in IJN, and I also have keep a few echoes cases that I get from when I was in Mayo Clinic. So I think today is a little bit special. So I just wanted to share the echo cases that I actually see in Mayo Clinic and share with you all. So this is a miscellaneous compendium of many different type of cases. Just wanted to share some interesting cases with you all. So we just started our first case. So this is a 44 years old man with history of shortness of breath at rest. So went to Mayo Clinic after more than 5 years follow-up at outside hospital. She actually was told to have non-ischemic cardiomyopathy with heart failure with reduced ejection fraction. So ejection fraction was actually 25% on the referral letter. Because of the poor ejection fraction, they did a coronary angiogram in outside hospital, which was normal. Therefore, the diagnosis is non-ischemic cardiomyopathy with heart failure with reduced ejection fraction. The patient have no non-medical illness, so he's fairly young, but 10 years ago, he actually have history of bilateral carpal tunnel syndrome that need a release surgery. So this is the echo done in Mayo Clinic. So Mayo Clinic, only one thing that is very different is that the echo is in Mayo format. I will show you what I mean later. Only one different, okay? So this is the parasternal long axis view of the echocardiogram. And you can see that ejection fraction is indeed down. So the ejection fraction here in Mayo is about 20%. But one thing that we can see here, obvious abnormality, you can see that the wall is thick. So the interventricular septum is very thick. The posterior wall is also thick, even though, but not as thick as the interventricular septum. So this is not typical of a garden variety non-ischemic cardiomyopathy or heart failure with reduced ejection fraction, in which the wall will be either normal or thin because of the formation of scar tissue. So this already gives us suspicion that the diagnosis of non-ischemic cardiomyopathy is actually wrong in this patient. And you can see the measurement. So the interventricular septum in diastole is 2.5 centimeter, and the posterior wall is 1.5. So the upper limit for male is 1.1 centimeter. Upper limit for female is 1.0 centimeter. So anything that more than 1.0 or 1.1 is considered abnormal wall thickness. Anything that is more than 1.3 centimeter is considered moderate wall thickness, and more than 1.5 is considered severe wall thickness. So you can see that this patient has severe wall thickness, somewhat involving more interventricular septum than posterior wall. And just going back here, because we are dealing with a thick wall, it's very important to also look at the mitral valve, because we want to see whether there's any SAM of the anterior mitral valve leaflet, because that can be suggestive of hypertrophic cardiomyopathy. So this is the apical four-chamber view. So this is what I meant by Mayo format. That's the only difference. So in Mayo, this is LV, this is RV, LA, and RA. Okay, so this is Mayo format. In other institution, any institution, including IJN, this is LV and this is RV. Okay, so today, because the echo are all from Mayo Clinic, so this is a Mayo format. So Mayo format, the left is left ventricle, the right is right ventricle. So you can see here, the ejection fraction is down, but again, you can see this symmetrical wall thickness that involve the whole of left ventricle. So just a zoom view, right? Again, you can see not only this involve the left ventricle, it also does involve the right ventricle. In fact, you can see also that the interatrial septum is also thickened. Normally, interatrial septum, especially some part of the interatrial septum, is thin. In fact, you can't really see the wall sometimes over here.
Oh, that's
But
very interesting. Okay, go on.
because that is usually the membrane primum, the place where you have your foramen ovale. But in this patient, you can see that the interior atrial septum is also thickened. In fact, the left atrial wall, the left atrial wall, the right atrial wall are all thickened. So everywhere there is a thickened leaflet, thickened wall, even leaflet is thickened. So this is the zoom view of the apical four-chamber view. And you can see here, I put a pulse wave Doppler across the LVOT, and you can see the LVOT actually changes bit to bit. So you can see that this is high, big, small, big, small, big, small. So what is this? So this is pulses alternance. So this is basically showing that the patient have very poor left ventricle and very poor cardiac output. So at every beat, there are different stroke volume that is injected by the left ventricle. Why does this happen? This happens because in a very weak left ventricle, the calcium metabolism is not efficient. So in every beat, there are different efficiency of calcium metabolism. So you have different stroke volume in each beat, otherwise known as pulses alternance. So this is very good to give you an idea that the cardiac output and the left ventricle function is very poor in this patient. So this is just a diastology. With a wall that is more than 1.3 centimeter, we know that the patient already had diastolic dysfunction. And we can see that the E over A ratio is 1.72. So either this patient have grade 1 diastolic dysfunction with normal left atrial pressure, or grade 2 diastolic dysfunction with elevated LA pressure at rest. So that one we have to look at the other parameters, which I will show you a little bit later. So you can see that the patient tissue is very unhealthy. You can see that the septal E prime velocity is only 3 centimeter per second. At least it need to be more than 7. In fact, in a 44-year-old man, it need to be at least more than 9 and 10. So the tissue is very, very sick. In fact, if we divide the E to E prime, is way above 14. So this patient not only have diastolic dysfunction, he also have very elevated LA pressure at rest. No wonder the patient is symptomatic and having shortness of breath even at rest. The lateral tissue is somewhat healthier, 8 centimeter per second, even though it's still below the threshold of 10 centimeter per second. And you can see here, there are tricuspid regurgitation. It looks at least moderate to severe tricuspid regurgitation. This is again the continuous wave blood Doppler across the tricuspid, the TR. You can see it is triangular. So a triangular Doppler is very suggestive of severe tricuspid regurgitation. And this is the hepatic vein Doppler, and you can see exaggerated diastolic flow reversal that I expect happen during inspiration that is very consistent with restrictive cardiomyopathy. When we do a global longitudinal strain, we see this pattern, which is very interesting. You can see that the apical is fairly preserved compared to the mid segment and the basal segment. So this is what we call a cherry on top appearance. And we also have what we call an apical sparing. So what is the summary? Then we can see this echocardiogram that the people from outside hospital actually miss and wrongly diagnose the patient as non-ischemic cardiomyopathy.
Can we see whether anyone can guess the diagnosis? Is it okay, Aslanif?
Sure, sure.
Yes, can anyone guess the diagnosis? Just type in your guess. You may be right if I say it's a guess, but of course you may be right. Okay, we have a lot of people with answers. We have Lim Liwei says it's cardiac amyloidosis, and then Dr. CH says amyloid heart. Okay, any more? Anyone else? Not too bad, huh?
Yeah, not too bad.
Yes.
They have a very smart audience.
Yeah, of course, of course. Okay. Okay.
So I mean, I think that, so this is very good answer. Basically, the answer is correct.
Yes.
This is actually
We go on, yeah.
amyloidosis. But I wanted to actually give you a tips on how to approach thick wall cardiomyopathy.
Okay, go on.
Yeah,
because there are people who need to know also.
So the summary from the imaging, EF is indeed very depressed at 20%. This shows you that patient with amyloidosis can have reduced ejection fraction, especially at the end stage of their disease. They are not always preserved ejection fraction. So poor cardiac output with pulses alternance. However, the wall is very thick. I always say that if the wall is more than 1.5 centimeter and the patient does not have hypertension and aortic stenosis or aortic stenosis, very suspicious of thick wall cardiomyopathy. In fact, even if they have hypertension and aortic stenosis, the thickness is rarely more than 1.7 centimeter. So just use 1.5 as the cutoff to start thinking very seriously about thick wall cardiomyopathy. So whenever you are facing with someone with thick wall cardiomyopathy, if you want to think about differential diagnosis, it's very easy. The approach is think about the three commonest diagnoses. The number one is hypertrophic cardiomyopathy. So this is the commonest one. Number two is cardiac amyloidosis. And number three is Anderson's Fabry disease. So you only need to remember these three. Apart from obviously the hypertension and aortic stenosis, strictly speaking, those are not thick wall cardiomyopathy. So the job for us as a cardiologist is to differentiate whether this patient have any one of these three. So why from the echocardiogram itself, we can say that this is cardiac amyloidosis, suspicion very high. Okay, obviously echo in by itself cannot do a definitive diagnosis. Doesn't matter how typical the echo appearance of cardiac amyloidosis is, you cannot base on echo alone, but it can give you an idea what is the most likely diagnosis. So the clue here, number one, wall thickness appear to affect all of the left ventricle. In hypertrophic cardiomyopathy, is normally asymmetrical if they present with a septal variant of hypertrophic cardiomyopathy or apical hypertrophic cardiomyopathy where it involves only apical region. There is hypertrophic cardiomyopathy that involve the rest, all of the LV, but it's rare. So this is number one that is against hypertrophic cardiomyopathy. Number two, there is no systolic anterior motion of the mitral valve. So this is less likely to be hypertrophic cardiomyopathy. Again, with a caveat, remember that many variants of HCM does not have systolic anterior motion. So you can have non-obstructive hypertrophic cardiomyopathy, okay? And in fact, many other conditions, including cardiac amyloidosis, including Fabry disease, even hypertensive heart disease, even aortic stenosis, apical Takotsubo cardiomyopathy, patient with apical myocardial infarction can also have systolic anterior motion of the mitral valve. So in echo, it's not very easy because it's not always black and white. So we have to use what I call a zeitgeist or the information of many different clues to get the diagnosis. And we can see that the tissue is very sick. The septal E prime is 3 centimeters per second. And the average global longitudinal strain is only negative 2.4%. So normal should be more negative than negative 18%. So very sick tissue where we know that out of all three conditions, usually those with cardiac amyloidosis have the sickest tissue. And the GLS, you can see apical sparing. So this is also typical of cardiac amyloidosis. And as I mentioned from the initial echocardiogram, not only the LV and RV, even the interatrial septum, even the left atrium, even the right atrium is thickened. So this usually does not happen in hypertrophic cardiomyopathy and also in Fabry disease. And this also explains why in patients with cardiac amyloidosis, they very commonly also have atrial fibrillation. And the LA pressure is very elevated. The patient have high E over E prime and very short deceleration time. So this is the clue. So from the echo itself, we already can see that most likely this is a cardiac amyloidosis case. Is there any clue from the history that this is cardiac amyloidosis? What are the other pointers?
Aslanif, sorry, can I ask you to explain why is Anderson Fabry disease?
So Anderson's Fabry disease is basically a genetic disease. It is an autosomal dominant disease because of deficiency of alpha galactosidase enzyme. The deficiency of this enzyme causes an accumulation of protein called globotriacylceramide in the left ventricle and cause thick wall cardiomyopathy. So I will show you how to diagnose Anderson's Fabry disease. It's the rarest out of all the three, but the thing is, Fabry disease can be treated by enzyme replacement. That's why it's important to diagnose it if it's indeed present. So it usually 5% of people diagnosed as hypertrophic cardiomyopathy is actually Anderson's Fabry disease. The other pointers that is extremely important is history of bilateral carpal tunnel syndrome. Bilateral carpal tunnel syndrome is relatively rare. If let's say you see anyone with history of bilateral carpal tunnel syndrome, if you are doing orthopedic or you are an orthopedic surgeon, and the patient see you because of bilateral carpal tunnel syndrome, they need to be investigated for TTR amyloidosis. Okay, and this patient, every time I see someone that have bilateral carpal tunnel syndrome, that have history of spinal stenosis, that have history of early onset atrial fibrillation are always suspicious of TTR amyloidosis. Whenever we're talking about cardiac amyloidosis, we are talking only about two. Either it is AL amyloidosis. This is a plasma cell dysplasia. So this is a malignancy. This is a medical emergency that need to be diagnosed within 1 or 2 weeks. Otherwise, the patient will die. However, AL amyloidosis usually happen in the elderly. So this patient is very young. So AL amyloidosis is much less likely. We send alpha galactosidase enzyme. So this can be done in IJN as well. So it's very easy to be done, which is normal. So if you want to diagnose Andersen's Fabry disease, very easy. Send for alpha galactosidase enzyme. The level is normal, then it's normal. If the level is low, then the patient has Andersen's Fabry disease. And you can try enzyme replacement therapy. However, even though the patient is young, because AL amyloidosis is such a devastating diagnosis that need to be treated as soon as possible, I send serum and urine electrophoresis with immunofixation and serum-free light chain to rule out AL amyloidosis. Okay, this is very important because when you do PYP scanning to confirm TTR amyloidosis, it can be false positive if the patient has AL amyloidosis. So you always have to rule out AL amyloidosis first. After that, I did cardiac MRI. And cardiac MRI indeed shows a typical change of cardiac amyloidosis, which is diffuse subendocardial fibrosis. So diffuse subendocardial left gadolinium enhancement, suggestive of cardiac amyloidosis. Okay. So after that, I did finally, because I want to do a positive diagnosis of TTR amyloidosis, I actually do a pyrophosphate scanning, which is a bone scanning. And it shows an avid tracer uptake of the myocardium, confirming the diagnosis of transthyretin amyloidosis. So basically, this patient have TTR cardiac amyloidosis. So what is TTR cardiac amyloidosis? So as the name implied, this is transthyretin. Thi stands for thyroid, retin stands for retinoic acid. So this is a protein that transport thyroxine and retinoic acid around the body, and it's produced by the liver. So in some patients, especially in young patients, they can have a mutation in the gene that code for this protein, and this can cause this protein to be misfolded and cause the accumulation of this protein inside the heart, causing thick wall cardiomyopathy. This is extremely common in the elderly patient that is usually more than 70 or 80 years old. In this situation, we call it the wild type TTR amyloidosis. They don't have any mutation, but somehow the tetramer of the transthyretin molecule is not stable. It's separated into its monomers, and again, it accumulates in the heart. Also cause thick wall cardiomyopathy. So this is my comment. The diagnosis for this patient was missed for many years, as cardiologists never suspected, or maybe not think about cardiac amyloidosis. If you don't think about cardiac amyloidosis, you will never diagnose cardiac amyloidosis. Okay, you have to think about it. Even though most cardiac amyloid start with preserved ejection fraction, there are instances, especially end stage, where the ejection fraction actually goes down. Now, if detected earlier, the treatment can be started earlier, and this can make the prognosis better. In a patient with AL amyloidosis, you need to diagnose earlier, because really the best hope for cure in AL amyloidosis is stem cell transplantation. That usually can only be done if you diagnose it early. In TTR amyloidosis, now we have a tetramer stabilizer called tafamidis. Tafamidis is the medication by Pfizer that can give a very much improved prognosis in patients with TTR cardiac amyloidosis. So it's very important to make this diagnosis. And it's also quite common. Some people say that about 20% of people that was diagnosed as heart failure with preserved ejection fraction actually have transthyretin cardiac amyloidosis. So what is my approach whenever I see a wall thickness that is more than 1.3 or 1.5 centimeter? So any wall that is more than 1.5 need to be investigated for thick wall cardiomyopathy. The first thing that I always do, I wanted to rule out AL first. So I send the serum and urine electrophoresis with immunofixation and serum-free light chain. And if that is negative, I have already ruled out AL amyloidosis. And I send alpha galactosidase enzyme. If this is negative, I already ruled out Andersen's Fabry disease. If not contraindicated, usually the contraindication for cardiac MRI is renal impairment. I will do cardiac MRI first. Why? Because the pattern of left gadolinium enhancement can give us idea of what is the etiology. So for example, if you have patchy mid-myocardial fibrosis especially at the left ventricle, right ventricle septal insertion, then most likely you are dealing with hypertrophic cardiomyopathy. And if you have diffuse subendocardial fibrosis, most likely you are dealing with amyloidosis. Now, if the cardiac MRI is suggestive of hypertrophic cardiomyopathy and my suspicion of amyloid is low, I will stop there and I give the patient the diagnosis of hypertrophic cardiomyopathy. Now, regardless of the CMR results, if I still suspect amyloid, then I will do a PYP scanning after a negative AL amyloidosis, like what I do for this patient, and it turned out to be positive. So this patient have transthyretin cardiac amyloidosis. So the sequence is blood first to rule out AL amyloidosis and Anderson's Fabry, MRI to look at the late gadolinium enhancement, and finally, if you think this is amyloidosis, you do PYP scanning to confirm the diagnosis of transthyretin. Remember that transthyretin cardiac amyloidosis, if the PYP is positive and the imaging fit with the diagnosis, you do not need cardiac biopsy or you do not need any biopsy. This is as opposed to AL amyloidosis, that even when everything is positive, you still need biopsy. It need not be from the heart, it can be from the fat pad, it can be from the rectum, but you need a tissue biopsy if you are dealing with AL amyloidosis and you want to confirm the diagnosis. Okay. So that is basically cardiac amyloidosis and approach to thick wall cardiomyopathy.
Can we go back to your echo slides, previous slides? Okay, hold on. Okay. Now, technically, okay, this one that one is fine. Technically, the thickness of the wall is not actually hypertrophy, right? It is deposition of amyloid, right?
Right. So it's not hypertrophy. I mean, the myocyte itself doesn't hypertrophy like in hypertrophy.
Yes, that's right. So right. I want to say that when you do an ECG, in actual fact, you don't see LVH. So
you are right. So basically, we say that if patient got left ventricle abnormal wall thickness and you see ECG with a small QRS complex, then you have to be suspicious of amyloidosis. Now, having said that, about 25% or 20 to 25% of cardiac amyloidosis does present with ECG pattern of LVH as well. So if you look at the ECG, if the ECG is the QRS is normal, yes, so you can suspect cardiac amyloidosis, but if it shows LVH, you cannot rule out. It is unlikely, but still amyloid can present with LVH even on ECG.
The other thing about it is that this is quite typical. There's this speckle kind of appearance, right?
Yeah, this is called the sparkling appearance. It's difficult for me to describe what is sparkling appearance, because it's just like a face. If you see
all the white dots like stars, you're gazing at stars, right?
Correct. So this is sparkling appearance of the myocardium, also very typical of cardiac amyloidosis.
The atriums are enlarged. Is it because of the regurgitation, or is it just a presentation of this amyloid?
It's a combination of both. So amyloid is another one of the restrictive cardiomyopathy. And if you remember, in your classical teaching, restrictive cardiomyopathy presented with biatrial dilatation with preserved LV and RV function. So this biatrial dilatation is because of restrictive cardiomyopathy. Because the LA pressure is very high, that's why the LA pressure is dilated. Then you have a secondary pulmonary hypertension, and then your RA size also dilated. And in addition to that, the regurgitation also contributes to LA and RA dilatation.
Well, very interesting case. And then I'm so happy that some of you got to guess the right answer. Okay, we go on to the second one and see how.
All right, so let's go to the second case.
Thanks. I'm so happy. I can't stop smiling.
All right, so our second case, we have a 45-year-old male that have progressive shortness of breath for the past 1 month. This patient denies any fever, but the patient looked lethargic, and the blood pressure is 124/32. So this is the patient echo. This is the parasternal long axis view. You can see that the aortic valve is somewhat thickened. The LV ejection fraction is actually normal. This is a zoom view, and again, the aortic valve is somewhat thickened. There is something abnormal about the aortic valve, but you can't exactly tell from these two views. Now, when we put color and you look at this parasternal long axis view, you can see that you cannot really see any obvious abnormality, either stenosis or regurgitation in this parasternal long axis view here. However, when you go to apical 5-chamber view, you can see the patient have aortic regurgitation right here. And the aortic regurgitation from here doesn't seem severe. Maybe from here, the color view, maybe at most, the color show moderate aortic regurgitation. This is apical long axis view on the left side. Again, from the apical long axis view, you can see a little bit of aortic regurgitation, nothing that will make you think that this is very severe. This is a short axis view of the aortic valve. Now, interestingly, you can see that the opening is somewhat oval. So this is the non-coronary cusp, and it seems that this patient have bicuspid aortic valve. This is the non, and this is the fusion of the right and left coronary cusp. It's not so clear. So the tips in terms of determining whether a patient have bicuspid or trilateral aortic valve is actually looked at the valve when it open rather than when it closed. If the opening look oval, it is bicuspid valve. If the opening look triangular, then it is a trilateral aortic valve. Now, when we look at the color seems not very impressive. At max, maybe we will say from the color view, it is moderate aortic regurgitation. However, when we put a Doppler, a continuous wave Doppler at the aortic regurgitation, we can see that the pressure half time is very short. It is less than 190 milliseconds. This means that the LV and diastolic pressure is so high that the pressure of the aorta equilibrate with the pressure of the left ventricle very, very quickly. So this does not happen in moderate aortic regurgitation. This is actually very specific for severe aortic regurgitation. So now we have a discordant data. We have a color view that shows at most moderate AR, but we have a Doppler here that shows very short pressure half time. Not only that, when we do a Doppler in the descending aorta, so this is the view, this is the flow during systole. This patient have a lot of flow during diastole, which we should not have. So this patient have hollow diastolic flow reversal. So throughout the whole of diastole, there is blood cells going back into the left ventricle. So this is also typical of severe aortic regurgitation. In fact, when you look even at the abdominal aorta, so this is more distal, even at the abdominal aorta, you can see that there is actually color flow that is going back into the ascending aorta and going back into the left ventricle. So you have hollow diastolic flow reversal even in the abdominal aorta. So if you have hollow diastolic reversal in the abdominal aorta, this cannot be anything else. The patient surely, truly have severe aortic regurgitation.
This abdominal aorta is done through what view?
This is subcostal view.
Oh, I see. Okay.
So this is subcostal view. So, but why is the color is not so impressive then? Okay. We look at the ejection fraction. The ejection fraction is preserved. People might think, or people might be taught that a patient with severe aortic regurgitation, the LV should be dilated and the EF should be down. But in this patient, the EF is preserved. The LV is not so dilated. Why? Even though the patient have severe aortic regurgitation. And why the patient have severe aortic regurgitation? We can see from the long axis view, there are some thickening of the aortic valve, but we can't really see what is the reason of the aortic regurgitation. As I said, there are color views showing regurgitation, but it's not very significant. So what is the AR severity? The AR severity is severe. Why? Number one, very short pressure half time. Number two, the hollow diastolic flow reversal even in the abdominal aorta. So whenever you see a discordant data like this, always trust what you see in the Doppler more than what you see in the color. Why is this? This is because this patient, rather than having severe chronic aortic regurgitation, this patient has severe acute aortic regurgitation. Now, in severe acute aortic regurgitation, because the pressure difference between the aorta and left ventricle come very, very quickly, the color turbulence might not be very obvious. That is number one.
I see.
Another thing, because this is acute, the left ventricle have not yet have the chance to dilate it. and compensate for the severe aortic regurgitation. That's why the LV is still small and the EF is still preserved. However, the patient is very symptomatic because the LV does not dilate, the pressure inside the LV is sky high. So this is the difference I want to show between acute severe aortic regurgitation and chronic severe aortic regurgitation. The last two slides, as I said, clinch the severity. So this is indeed severe aortic regurgitation. And in fact, from the presentation of the patient, we can see wide pulse pressure. You can see that the diastolic pressure is only 32 and the systolic pressure is 132. So whenever you see a wide pulse pressure like this, so always be suspicious of severe aortic regurgitation. Now the aortic valve also appear to be bicuspid. So from here we are diagnosing acute severe aortic regurgitation, but we still don't know why is the reason the patient have acute severe aortic regurgitation. In this case, we need to do transesophageal echocardiogram. So I do a transesophageal echocardiogram for this patient. So this is the transgastric view of the aorta. So you go to the transgastric view, usually at the 40 centimeter level of your probe. So this is the aorta here. Again, you can see the aortic valve is abnormal. You can see aortic regurgitation, but you can't really tell for sure what is the abnormality. No matter, we go to another view. And finally, in this view, you actually get the answer. Okay, you look at this. Okay, so this is what we call the non-coronary cast, and this is the non-coronary cast, and this is the right coronary cast in the trileaflet aortic valve. In the bicuspid valve, this is the non-coronary cast over here, and this is the fused right and left coronary cast. Now, if you look at the zoom view here, and if you look at my pointer there, you can see that the non-coronary cast is actually perforated with vegetation attached to the perforated segment. Okay, even the right coronary cast, if you see here, if I were to pause, you can see that even the right coronary cast, you can see the echo-free area in the non-coronary cast as well. So basically now we have the answer of why the patient have severe aortic regurgitation. This is because infective endocarditis of the bicuspid aortic valve cause perforation of the non-coronary cast and also right coronary cast. In fact, now we can see severe aortic regurgitation from the color flow. And here we can see a beautiful description of bicuspid aortic valve. You can see clearly during opening that the bicuspid valve opening is oval. You can see clearly a raphe between the left and right coronary cast here that is fused. And in fact, you can see here, if I were to pause, okay, just go a bit there. You can see there's a hole there at the non-coronary cast. So that is the perforation that we see
yes.
parasternal long axis view there. So the conclusion here, this transesophageal echocardiogram actually gives us the answer. This is indeed severe aortic regurgitation. It is not severe chronic, but severe acute aortic regurgitation. The patient have bicuspid valve with fusion of the right and left coronary cast. It is the most common bicuspid valve, followed by the fusion of RCC and NCC, and finally the rarest is LCC and NCC. As I said, we can see perforation of the NCC with vegetation and also possible perforation of the fused leaflet as well. So this is acute severe aortic regurgitation. So what is the lessons from this case? Acute severe AR present differently from chronic severe AR. In acute AR, the color might not be so impressive and the LV might not be dilated. The severe nature of the AR need to be inferred from diastolic flow reversal, short pressure half time, and also the wide pulse pressure. Sometimes TTE alone is not enough. In this case, it is only clear that this is infective endocarditis from transesophageal echocardiogram. So this is the second case of infective endocarditis involving the bicuspid aortic valve.
But usually in the case of aortic regurgitation, right? Even in chronic, initially the LVEF will be preserved or even increased, right?
For chronic AR, no. For chronic MR, initially the EF will be increased. For chronic AR, usually initially before it normally it becomes severe first. When it becomes severe, normally at that time, the LV is not dilated yet, but the LV diastolic volume, usually once you have severe artery regurgitation, the diastolic volume is already dilated, but the systolic volume is preserved and the ejection fraction is preserved. As you progress, then your systolic volume will also be dilated, and then after that, then ejection fraction will start goes down. So at the beginning of severe artery regurgitation, the EF is preserved, the systolic volume is preserved, but the diastolic volume and the diastolic dimension is usually dilated.
Okay, the other question I would like to ask you, are you done with this case?
Yes.
Okay, how do you treat? Okay, do you, I mean, of course, antibiotic and eventually you will need an aortic valve replacement, but how long do you wait for this aortic valve replacement?
Okay. This is a very interesting question and very, very important. I mean, the problem is usually not all the surgeon would like the patient to be on antibiotic for quite a long time before they wanted to go for surgery. Actually, this practice, I think, is not correct. For
Yeah.
me, if the patient is unstable, for example, if the patient have heart failure, the patient have very large vegetation that is more than 10 millimeter or more than 1 centimeter, usually I will try to bring the patient to OT as soon as possible. I do not wait for the antibiotic. I continue the antibiotic after the operation. If let's say can wait, for example, the patient is stable, the vegetation is small, the risk of embolism is low, you can wait. Normally, I wait maximum 2 weeks of antibiotic before I push the surgeon to do surgery. Now, I repeat one more time. If the patient is unstable with heart failure or high risk of embolism, I try to do it as soon as possible within 2 or 3 days. If the patient is stable, I usually wait, but not more than 2 weeks.
Okay. Somebody asked me, I know what's the cause of infective endocarditis in this patient. I guess what microbacteria is it, right?
So this patient actually have streptococcus inside the blood, virident streptococcus. The patient have history of dental manipulation that is done about 1 month before the presentation. So even though the patient does not have fever, but the patient in fact have infective endocarditis, it can happen. Infective endocarditis does not present with fever, very, very rare, but it does happen. So the absence of fever does not rule out. And yes, the most common cause of infective endocarditis in native valve is streptococcus bacteria.
Okay, very nice. Okay, got some more cases?
Yes.
Oh, great.
You can stop me whenever you want to stop me. There are too many cases to go.
Okay, no worry. We do
Right.
one more, and then after which we will do this kind of cases on a regular basis next year, Ken?
Sure, no problem.
Okay, come, we go on.
So this is a short cases. So I have multiple short cases.
Okay.
So this patient have post mitral valve replacement. Okay, and then patient have pansystolic murmur post mitral valve replacement. Patient is a 67 years old female who now has dyspnea even on minimal exertion. So this is a parasternal long axis view. So this is a replacement of the mitral valve. In fact, this is a biological mitral valve replacement. No, the mitral valve is actually working well. There is no stenosis. There is probably trivial regurgitation that is non-pathological. So where does this pansystolic murmur come from? So this actually come from here. Remember again that this is a Mayo format. Okay, so this is the RV, this LV, RA, LA. So what do you actually see here? What you see here, actually, you have a shunt coming from the left ventricle into the right atrium. Okay.
Oh my God.
When we think about the shunt either from LV to RV, which is ventricular septal defect, or LA to RA, which is the atrial septal defect, right? But in this patient, the shunt is between the LV and right atrium. So this is what we call a Gerbode defect, Gerbode, Gerbode defect. I will tell you what it is afterwards. So this is a shunt that is rare between the LV and RA. So this one, you can see the color flow from the LV here through the shunt into the right atrium. The patient also have pacemaker. So this is a tricuspid valve. Another thing that you can see here, the pacemaker lead actually preventing this leaflet from coaptating. So this patient also have tricuspid regurgitation secondary to pacemaker lead impingement. Okay. So the abnormalities seen here, as I said, this is short cases. So this patient post mitral valve repair have two issues. Number one, the patient have severe pacemaker induced tricuspid regurgitation. And number two, the patient have iatrogenic Gerboldi defect post mitral valve replacement because of shunting between the LV and RA. So Gerboldi defect can happen in two ways. Number one, because of iatrogenic. So patient go for surgery. For some reason, during the surgery, the surgeon inadvertently puncture the wall between the LV and the right atrium. Later, I will show you why this can happen. The other reason this happens is congenital. In a rare way, your perimembranous BSD is normally between the LV and RV. Sometimes the perimembranous BSD can be higher up, and in fact, it can be at the region between the LV and the right atrium. So you can have the Gerboldi defect that way as well. So two ways, either iatrogenic or congenital. So this, I show you why we can have this Gerboldi defect. Why do we have this? We have this because, remember, the tricuspid leaflet attachment is more apical than the mitral valve in all of us, okay? The tricuspid is always more apical than the mitral valve. Now, because it is more apical than the mitral valve, there is a potential wall here, you see the arrow here, between the LV and the right atrium. So any hole here can cause a shunt between LV and RA and can cause Gerboldi defect. Now, the Gerboldi defect has many different variants. In the case that I show you just now, it is a straightforward supravalvular Gerboldi defect in which the hole is between the LV and RA. You can also have this indirect Gerboldi defect. The hole is actually between the LV and RV, but the hole is orientated in such a way that the shunt go through to the RV and go through the tricuspid valve into the right atrium. So this is
the tricuspid valve is actually perforated.
No, it go in between the tricuspid valve.
Oh.
It's not perforated, but it goes in between. Because the pressure is very high, it cannot control that pressure because the pressure is from LV. And finally, the last one is intermediate. So this is when you have both. We have the hole at the ventricular septal level and also the hole here that cause shunt through both here and also here, right? So this is this variant here. I will show you the other variant in these cases. So we have a 27-year-old male. Patient again is symptomatic with pansystolic murmur, but this patient have no history of cardiac surgery before. So this is a parasternal long axis view. Whenever patient have membranous or supracrystal ventricular septal defect, you actually can see shunt here below the aortic root. So you can actually see some turbulent flow here below the aortic root. Yes. Now, if you go to the short axis view, all right, now you can actually see that the hole is actually here. So that's the hole there. However, you can see that the flow go through here and go into. So this is a short axis view just to orientate. This is the left atrium here. This is the right atrium there. And this is the right ventricle and the right ventricle outflow tract. This is the aortic root here. And this is the hole here. Okay. Now, if you look at the flow actually go through the hole into the RV, then through the tricuspid valve into the right atrium, which is our infravalvular type of Gerboldi defect.
And this patient had no operation done?
No operation done.
So this is a congenital? Yes,
this is a congenital membranous, typical type of perimembranous ventricular septal defect. Rather than only going to the right ventricle, it go into the right ventricle through the tricuspid valve, then it go into the right atrium. In fact, if you look at the RV inflow view here, the flow that you see here is not tricuspid regurgitation. The flow that you see here actually the flow from the Gerboldi defect. Why is this important? This is important because you can wrongly say this patient have severe TR. Now, because the pressure is very high, if you measure the peak gradient in this patient, the peak gradient is more than 120 millimeter mercury. And you can erroneously diagnose the patient as having severe pulmonary hypertension, when in fact this is not severe tricuspid regurgitation, this is not severe pulmonary hypertension, this is actually just a perimembranous VSD with shunt from the LV into the RV into the right atrium that can mimic severe tricuspid regurgitation. So another body defect, LV to RV to RA. In this case, it is congenital. This is perimembranous VSD. The shunt is infravalvular. Like I said, go from LV to LV and then to the right atrium. And very important, as the jet can be confused as tricuspid regurgitation. And you can see here what I meant. So this is the first case, the iatrogenic case, straight away from the LV to RA. My second case is the one that is indirect perimembranous VSD from LV to RV, but rather than going to RV alone, like a typical VSD, actually go into the right atrium. So this is a second case of Gerboni defect of infravalvular variant. So that is my short cases images 1 and short cases images 2. So whether you wanted me to continue or you wanted to stop here.
Okay. I think we stop here. It's already 9:50 and we
Sure.
will take some questions.
Sure.
Okay, so for the example, the one with the aortic, the mitral valve replacement, in all cases, you need to go and repair this body, right?
Yes, because the pressure difference between the LV and RA is so high. If you don't repair, the RA will become dilated, and later the patient might develop pulmonary hypertension. So usually, unless it is extremely small, then maybe you can get away, and the patient is old. But normally we have to close it. In fact, what we can do is we can do transcatheter closure of this hole.
You can do transcatheter closure.
Yes.
Using
Amplatzer device, the one that you do for your ASD.
ASD?
Yep.
Oh, that's very interesting.
Yep. I have a case that I don't have in my slide now in my library of whereby we close this Gerboni defect with an Amplatzer device.
Okay, we have a question from Dr. Kamala that amyloid heart, what are the changes in the ECG? I think we discussed shortly, but you can repeat that.
So basically, in cardiac amyloidosis, the typical or classical teaching is that you see a small QRS. So you get a bit confused, right? You can see the LV wall is thick.
Okay, you
so
don't get a small QRS, but you do not get a characteristic of LVH kind of ECG. Your QRS is still about the same size.
Correct.
Yes.
Okay, but again, I wanted to remind you that a big QRS does not rule out amyloidosis. They are minority of amyloid with LVH pattern ECG also.
Is it common to see pericardial effusion in amyloidosis?
Yes, it is very common. One of the pointer that the patient that have cardiac amyloidosis. The reason being, you know that the pericardial fluid actually is absorbed back into the right atria. And normally in patient with cardiac amyloidosis, the right atrial pressure is very high, so that the patient cannot reabsorb back the pericardial fluid. So many times they actually have pericardial effusion as well. Usually not a lot, but they have pericardial effusion.
Yeah, I think your patient has a rim of pericardial effusion just now. Yeah. Okay, any more questions? I like this type of cases so much, you know why? Yeah. Because I myself have not even seen your body. I never even knew the existence of it. So I feel so happy. I can't start smiling because I learned a lot. And I would really, maybe we can make this type of webinar on a regular basis next year. I will message you. Any more questions? Any more questions at all? It's very interesting, and I think I want to reach out to more, maybe not so much the GPs. This is very interesting for medical officers, people who have interest in cardiology. Physicians with interest in cardiology should join us. So, and we don't need physical meeting for this, because it's so easy, just spend your time. Anyway, for the nurses, right? Please kindly go to the Facebook page of Beating Hearts, and the eCert registration is shared there. I'm going to share the doctor's QR code. Okay. Okay. See whether you can scan it. Azani also can scan. Azani, but Aslan is okay. Let me try to scan. And then before I forget, Happy New Year and Merry Christmas. everyone.
There are one final question in the chat box.
Yes, that's right. Chat. We're taking questions still. Oh yeah, do you mind reading? Because once I share screen, I can't see the chat.
Sure. So
Yeah.
the question here is that stem cell transplantation, will it help in amyloid heart? And what is the lifespan? Is it fatal? So AL amyloidosis untreated is extremely fatal. So AL amyloidosis, usually when the patient presented to hospital, usually they will die within 1 or 2 weeks if you don't diagnose it quickly. Okay, very, very fatal condition. That's why you have to diagnose it very quickly. So as a rule of thumb, if you suspect AL amyloidosis, you try to get the diagnosis within 1 week. So send the serum electrophoresis with immunofixation and serum-free light chain, and make sure you trace it and call the lab saying that you want to result as soon as possible. Now, yes, the stem cell transplantation, if you do it in early enough, in the correct candidate, is actually curative. We actually can cure AL amyloidosis. If it's too late, then you have chemotherapy. Usually they are a combination of melphalan, they are steroids, and also they are, I think, a chemotherapy called bortezomib. I might be wrong. So they are chemotherapies, chemotherapy for AL amyloidosis. But going back for stem cell transplantation, that is the best chance for patient to be cured from AL amyloidosis. That's why it's very paramount to diagnose AL amyloidosis as quickly as possible.
Okay, I want to ask a question following that. Obviously, not everybody can go for stem cells, and I also have a patient of my own who has amyloidosis of the heart, because she has what you call that, the multiple myeloma. Now, how would you treat the heart failure?
The heart failure treatment is extremely difficult. Normally, we are judicious use of diuretics like furosemide. Maybe you can use spironolactone. This patient tolerate beta blockers, ACE ARB extremely poorly. So usually this medication is not useful in this patient unless the heart rate is very high that you have no option but to control it. So I would just say only the combination of diuretics, and that's all.
Yeah, it's very difficult because she's hypertensive, and I mean, is ACE inhibitor and beta blockers are not advisable.
Yep, not advisable.
But she's actually doing well on just diuretics, and I use physiotens for her high blood pressure instead.
Okay, that's very interesting.
Yeah, I had not much choice.
So we have another question here from Dr. Lim Liwei. Do you calculate the relative regional strain ratio in echo for suspected amyloidosis? So just wanted to explain what is relative regional strain ratio. So you get the average GLS of the apical region. You divide with the average GLS of the mid and the basal segment, and you see whether the ratio is more than 1. If the ratio is more than 1, it is very, very suspicious of cardiac amyloidosis. So in answer to your patient, yes, I do calculate the relative regional strain ratio. If it's more than 1, it's further telling me that this is more likely to be cardiac amyloidosis. But I don't use it to rule out. Never use this kind of thing to rule out amyloidosis. You only rule out with your blood investigation. And some people ask, can rheumatoid arthritis cause amyloidosis of the heart? Now remember, the one that is relevant is only 2, which is AL amyloidosis and TTR amyloidosis. And both of these cannot be caused by rheumatoid arthritis. Now, rheumatoid arthritis can cause a certain amyloid deposition on the heart, but this normally does not cause thick wall cardiomyopathy that we see in the normal cardiac amyloidosis.
Is it worthwhile to screen their relatives?
Yes, if let's say in this patient with young patient with transthyretin cardiac amyloidosis, we always have to send blood for genetic and screen their first degree relative, because this is most likely an autosomal dominant condition.
Sorry, okay. If you are keen to buy insurance, do look at what you call that.
Okay, I got another question. I'm very scared that I cannot answer everyone. So do we need biopsy to confirm the diagnosis of heart amyloidosis? So I think this one, just remember, okay, I think this is very important. If AL amyloidosis, let's say your serum, your blood investigation is positive, and you want to diagnose AL amyloidosis, you need biopsy. But the biopsy does not necessarily to be cardiac biopsy. Okay, if your echo is typical, your blood is okay, is positive, and you take a fat biopsy showing AL amyloidosis, then you can diagnose cardiac amyloidosis, AL amyloidosis, not necessarily cardiac biopsy. That's AL. AL always have to have tissue confirmation. For TTR amyloidosis, on the other hand, you do not need tissue diagnosis. For TTR amyloid, if your imaging is typical, if you already rule out AL amyloidosis, you only need PYP scanning. And if the PYP scanning is positive, you can diagnose TTR amyloidosis without needing biopsy.
Okay, I'm going to stop share. Wow, there's so many. Okay, everybody can see the QR code, right, just now? I even managed to scan it myself. I don't understand why nobody can see. Okay, I'm going to share it one more time. I'm going to stop recording.